Okay, welcome everyone to the Psychology, Diabetes and COVID-19 webinar series. Thanks for all joining us. Today's topic is health professionals with diabetes, so we're really looking forward to it. As always, please could you, if you're not talking, please could you keep your mics muted, and the audience, please could you just keep your videos off, just to help optimize things at our end. That'd be great. So please do, I know I say this every week, but please ask us questions in the chat function. I know we normally ask questions towards the end, but just write them as you think of them, and we're going to be noting them down ready to feed to our guests a bit later on. So that helps us, and also so we don't miss things. So get them in as soon as you can. You can, if you would like to, you can ask them in person. If you want to put on your video and turn on your mics, you may. Let us know in the chat function if you prefer to do that, and we'll organise that. But be aware this session is being recorded. I don't think I've missed any housekeeping things, so let's introduce everyone today. So I'm Becky Upsher. I'm a researcher in the Diabetes, Psychiatry and Psychology Research Group at King's. I'm joined by Professor Khalida Ismail and Emma Konstantara. Would you both like to introduce yourselves first?
Thanks, Rebecca. My name is Khalida Ismail. I'm a diabetes psychiatrist. I'm based at King's College Hospital, but also part of King's Health Partners, which also includes Guy's and St Thomas's Hospital, South London Maudsley Trust, and King's College London, the university.
And hello, my name is Emma Konstantara. I'm a PhD student at King's College London, and I'm working on eating disorders in type 1 diabetes. Today I will be taking care of the chat function. If you have any questions, please feel free to write them there and I will answer to you. If you want to share something privately, just double click on my name and you will be able to send me a direct message.
Thank you both, and we're joined by two great guests today. We have Kelly Carden and Debbie Cooke. Thank you both for joining us. Would you like to introduce yourselves?
Hi, yes, as you said, Rebecca, I'm Kelly. I'm here today as a person living with type 1 diabetes, but I also work within diabetes. I'm a diabetes specialist nurse working in the West Hampshire Community Diabetes Service, and that's in Hampshire.
Thanks, Kelly.
And hi everyone, it's good to be here today. I also have type 1 diabetes. I'm a health psychologist and I'm an academic working at the University of Surrey.
Brilliant, thank you both for joining us. And Emma, did you have a question for the audience before we start?
Yes, so today we wanted to ask, how would you feel if you found out that your healthcare professional had diabetes? Would you see it as a positive or a negative? Would you feel more or less comfortable with them, and why? Please feel free to share the answers on the comments. Thank you.
Thanks, Emma. And I'll hand over to Khalida. Thanks.
Great, thanks very much everybody, and for our new our guest today. So just to give you a bit of an outline of the purpose of these webinars for those of you who are joining us new, this is meant to be an online interactive forum for people with diabetes, specifically to talk about the psychological aspects of living with diabetes. And we've had different topics, and today's topic is about having diabetes, but also being a health professional working diabetes. And certainly I have noticed that a lot of my diabetes colleagues as health professionals also seem to have diabetes. And I think there's really interesting discussion to be had around that. So I'm very pleased to start off with inviting Kelly. Thanks very much, Kelly, for joining us. And just perhaps if we could start by just asking you a little bit about yourself, you know, like approximately how old you are, where do you live, and what do you do for a living? I know you've already told us a little bit, but perhaps a little bit more.
Thank you, Khalida. Firstly, thank you for inviting me to speak today. I have watched some of these sessions already, and they're extremely helpful, not only as someone living with type 1, but also as a healthcare professional, learning from others and hearing their experiences. So it's really important, and I'm so happy that these were set up to support people with diabetes. I am, oh goodness, how old am I now? 37 years old, and I live in Southampton, and I I'm a qualified nurse for nearly 3 years now, so not that long. But due to my experience, I kind of sidetracked into diabetes nursing. So I've been fortunate enough to begin a career as within a development role and become a diabetes specialist nurse. So that's been really helpful as well. Yeah, and I was diagnosed with type 1 quite not late in life, so I sound not that old, but at the age of 31, so not the typical age of what many people would view when you'd be diagnosed with type 1 diabetes.
So tell us, so you're saying that you started nursing quite late in your career?
Yeah, I did. So although when I was 19 and in my early 20s, I was offered a place at university on 2 occasions to do children's nursing. At the time, my life took off in different directions and I was offered different opportunities with work. So at the time, I went with what I was going with then. And I decided in I think it was my early 30s, I may have been 29, that I thought, actually, I still want to do nursing. I really want to go into it. So I'd done another course, an access course, because I've been out of studying for quite some time, and decided to take a year out. And that's when I become really unwell and was diagnosed with type 1. So within that time, I thought, hang on a moment, life is far too short. And within months, I'd secured a place at university and left my job and started university. So it was a bit of a whirlwind, really. It was a bit of a push in the direction that I'd always been aiming to go into, but it always had reasons why I couldn't. Yeah, it was quite...
Did you see it as a coincidence that you got diabetes just as you were thinking of going into nursing?
No, it was really, really bizarre. But yeah, it must have been a bit of a coincidence because it's the push that I needed, really, because I'm not sure I would have taken that year out, and I'm sure there would have been many reasons why, as a mature student, I was unable to study. And I think that would, whether or not I would have continued to pursue a career in nursing is another thing. But yes, I think it's the push I needed.
In a way, it bonded the two together.
Yeah.
And now you're actually trained to be a diabetes specialist nurse. So that's really fantastic. So tell us what that was like for you, being diagnosed with diabetes, sort of almost out of the blue.
Yeah, it was very, at first, because of all the symptoms that I was experiencing, and whilst I had very, very little knowledge of diabetes, it was like, no, this is definitely not happening to me. And yeah, I'm not really that unwell. And when I was diagnosed, it was quite a relief to think, oh, this is what the symptoms are, and there's a reason for this, and I can be treated for this. But I think reality started to settle in weeks, months later, that actually it wasn't just having a few injections a day. It's a whole lifestyle change. All of a sudden, I had to count carbohydrates and adjust insulin doses and meet all these new people, like in clinics, and share my life with them and tell them about things that I'm doing or not doing and what my diet was like. Am I active? Am I exercising? And then you had that sharing with your friends and your family and thinking, I don't want to be hyper in front of people. I don't want to look like I need help and support. So it was really, really, it's a huge lifestyle change. And then it was the carrying of everything in your bag. And I don't know about anyone else, but my handbag is always full of items, and trying to fit that into my life was a bit of a nightmare. And I could no longer just quickly get up and run out the front door. I had to make sure I was safe to drive. And if I wasn't, I had to treat the hypo. And it's very, very overwhelming all of a sudden, because it feels like, yeah, you've got your diagnosis and you just need a few injections to actually, this is 24/7. It is a lifestyle change. And it's actually really quite difficult, especially if you're quite a private person. I was thrown into this world of having to share my experiences with these healthcare professionals that I had never even met before. And I didn't particularly want to keep going to hospital appointments and then telling my employers that, oh, by the way, I have type 1 and if I go low, I may need to take a break. I'm like, I don't want to know this. So yeah, it was very, it was different to the life that I knew. So, yeah.
Yeah, that's really interesting, isn't it? That literally what people, that overnight your life changes. I remember a patient once said to me that even though he was only 7 or 8, when he got diabetes, he said, I knew that my life was taking on a different course. You know, I knew that my future was going to be different in some way. And you also refer to that loss of spontaneity, don't you? That sort of, you can't just rush out the house with your handbag, and there's, you know, so that must have also been quite sort of sad for you.
Yeah, it is. You kind of, because I think obviously there's circumstances within all of our lives that happen that we don't have planned, or if we have things that we want to do and they don't go to plan, there's a little bit of, I suppose, some grief of the loss of something that you were particularly having. And I hadn't planned this in my life. I hadn't planned to become unwell and have a long-term condition. But equally, and I always say this, and it's not, I suppose it's not justifying, but at the same time, I think actually things could have been a lot worse. And it's not all doom and gloom as well, because my diagnosis pushed me to do a lot more than what I probably would have done. So there's a balance, but yeah, it was quite difficult, and it can still be difficult at times, because you think, I don't want to. When I was a student nurse, you think, oh, I'm going on another placement, I'm going to have to tell everyone that I have type 1, just so they know, just because I'm checking my blood sugars and I need to make sure I have my breaks. So you just have to, you learn to maybe deal with it, and it may be tough, but actually, you know, it's the safest option to make people aware.
Yeah. And you also, I mean, so how did you started off with nursing, but then what, I mean, in a way, it's a really obvious question, what drove you to diabetes nursing? But from a psychological point of view, what do you think it was? Do you think there was I wonder if there was an element in which, by being with the diabetes fraternity, as it were, that you would be looked after in some way, or that you could be kept an eye on?
No, it wasn't that. I think that sounds, actually, when I think about it, I'm like, oh, I wonder if that was part of it, but I don't feel that was. For me, when I was diagnosed, unfortunately, through some experiences, they weren't really great. And then I started to notice that actually, at my age, there wasn't really a lot of kind of peer support around. And there were places that I could be signposted to, but not really anyone being diagnosed in their like late 20s, early 30s. And for me, that was a big gap. And I thought, actually, I don't other people to go through the experiences that I'm experiencing. Is this happening for other people? So I took to Twitter, and I've never used Twitter before in my life, couldn't get my head around it. And all of a sudden, I was welcomed into this diabetes online community. And I started to learn things about what services and the care that I really should be getting. And it's quite shocked to think, actually, I'm not necessarily getting these needs met, and I don't really know what I'm doing. I have type 1, but I don't really know. I'm not under a team, I'm not under a service. So that led me to start exploring about what's available. And I got in contact with, or was put in contact with, the service manager for the West Hampshire community team, and she was also looking to set up a peer support service. So from there, we started meeting and working together with some other charities and people with diabetes to see what could be put in place for people, particularly those who were newly diagnosed and particularly those with type 1 diabetes. And it was from there that I realised that actually I really enjoy working, like learning so much more about diabetes and working alongside others who have diabetes as well, and ensuring that services are enhanced and adapted to meet everyone's needs. And it was that drove me to want to work into diabetes care, because I thought there's a few gaps here, and actually I want to help make those changes to improve experiences for other people. So for me, that was the drive.
Yeah, that's really interesting, isn't it, that you're saying that you actually you getting diabetes, it made you you could see some of the gaps, and you wanted to actually help other people with diabetes through your own experiences of what was working well and what wasn't. So what did you notice that wasn't working so well? What was it, like things like the attitude of staff, or you said things like for a person who's very private to have to talk about herself in such a way? What was it that you picked up that wasn't good enough?
So definitely the way in which you're spoken to or at, not necessarily from your diabetes clinic, but I was unwell maybe a year into my diagnosis or so, or 6 months. And because I had an infection, it impacted on my blood glucose levels, which obviously I just couldn't manage. So I had to go into hospital. And I soon realised that the attitudes of other healthcare professionals were that if you have diabetes, you should be managing it. And and I think a couple of comments were made where, did you eat too many sweets as a child? And I'm like, oh. And actually, with regards to what the consultant had asked with the insulin infusion that had been set up overnight, although it was requested that this needs to keep running, the staff did not follow that and they wouldn't listen to me. So then they took it down, said I had to eat. And when I was like, no, if I eat, I need to have insulin. They were like, no, you don't. Your blood sugars won't go that high. And I'm like, it's not coping. My blood sugars are going really high every time I eat. And they just wouldn't listen to me. And subsequently, after saying, you need to have these 3 biscuits, I think it was like 3 a.m. And in the end, I was just like, okay, that's fine. And I then went back up into the 20s, and then they had to restart all the insulin again. And I just thought, this is really unheard. I live with this 24/7, and I wonder why you're not really taking on board what I'm saying. And then when I went into diabetes nursing, it became more difficult. So if I was unwell, which I was last year, I had a nasty infection again and had to go in, and it was only for a few hours to help bring down the blood sugar levels and rehydrate. And within the accident emergency department, when the nurse came to see me, the first thing she said to me, so for me, I'm always like, hi, my name's Kelly. We want to put people at ease. And she's like, oh, we've just come in to have a giggle at the diabetes nurse, sick with diabetes.
Wow.
Oh, and I felt horrendous at that time. And normally I'd be like quite angry. And I just went, oh, we get sick too, you know? And she's like, wow, yeah, no, but not with like nearly DKA. And I'm like, wow. And I just realized that people's attitudes are very, if you've got a health condition and you work in that particular area, you're seeing that you shouldn't be unwell. And actually, that's not the case. If anyone works with diabetes and particularly lives with diabetes, you realize that it's very much, it's not that easy to manage. It's really not.
But it must have been a very humiliating experience. And I think also your point about the huge expectation, if you've got diabetes and you're working in a diabetes setting, the huge expectation on you to be perfect with it, if you're going to impart that knowledge to other people with diabetes, isn't it? That's what you're saying. So are you, what other, I mean, that's a really good example of stigma. What other examples of stigma have you had in the workplace?
I think while I was a student nurse, I was training to cycle London to Paris. So it was a big thing for me. It was maybe 3 years after my diagnosis, and I wasn't that active, well, not to the point where I was cycling 60 odd miles a day. And I was learning how to manage my blood sugar levels and to have that fine balance of, you don't want to be hypo, but you don't want to be too high, because then climbing those hills are bad enough, let alone bad enough if you've got high blood sugars and the extra strain it puts on your legs. And I was blogging about my experience. So to help others to see, you can do this. These are the tweaks that I made, and it's not easy. And of course, I am going to experience hypos, because it's a fine balance again of what you need to fuel your body with, and do you need to reduce insulin. And during this time, I had a phone call from one of the leads at university saying, oh, I'm calling you. We've had a nurse from, and I think she was from up north, saying that they're concerned that I'm having hypos and I shouldn't be having hypos, and therefore should I be a nurse? And I had to stop the conversation and say to the person, have you actually read my blog? And she was like, no, I haven't. I said, and do you know much about diabetes? Like, well, yeah. I said, well, you know that hypo is, you know, it's not something that people want to have.
Yeah.
And it just made me, I think it was from that very start, so like, wow, there's a huge expectation already that even if I'm not a diabetes nurse, that because I'm a nurse, I shouldn't have hypos, can't be unwell. And I think, wow, I wonder what that's like for a GP if they get a cold. Is that something that they're allowed to have? Or, or someone working as a psychologist having
Depression.
yeah, exactly. And needing support from hospital, needing urgent care. Would someone then turn around and say to them, oh, look at that, that's funny. Someone who works in psychology is struggling with their own mental health. And I just feel it wouldn't be done. I feel that, with mental health side of things, it's more acceptable, it's more accepted, there's a lot more work that's been done with mental health and stigma has reduced greatly. But I feel with physical health, there's still that you should be doing this. You really should know better. So yeah, there's a few stigma stories, but it's the ones with the can you eat that and should you eat that? And sometimes I think, oh, I wonder, I think it was Liz, and Liz may be on the call today, Liz Warren. And I saw one of your messages about someone asking you, and I think your response is, why has it been poisoned? And I recently started to get the courage to actually say that to people, like, oh, have you poisoned it? Or have you licked the biscuit before? Is there a reason I can't eat this? But I do think, I don't know how people find it acceptable. What would their response be if I said, well, actually, no, I can't eat that bar of chocolate? I'm not sure they would say anything about it, because you wouldn't, would you? But
I think what you're saying, Kelly, there's lots of insidious comments that are constantly being made. There's the obvious ones that you described that are pretty horrendous, I think, actually. But there's these subtle ones, aren't there? Like, did you bring it on yourself? Did you eat too many sweets as a child? And I think the one, should you be eating this, is such a recurrent theme in both my clinic, in talking to other people with diabetes, and on these webinars. And I'm quite interested, and maybe Debbie, when she comes in later, and all the people listening to the chat function, is that could we have one stock response that nips that question in the bud? And I think we shouldn't, I mean, it'd be interesting to see if we can come up with one consensus statement that everybody can, with diabetes and their loved ones, can turn around to somebody who says, should you be eating this? How to stop that conversation. Because it's the constant erosion, isn't it, of your privacy and your human rights to do what you want. Maybe what we will do here, Kelly, is stop, and because a lot of people have been talking on the chat, and Emma has been very diligent in going through all the questions and trying. Emma, would you like to just give us a bit of a summary of what people are saying in the chat function? If anybody else wants to bring up a point that we can just have a discussion, then we'll come to Debbie.
Yes, so we don't have any questions yet, but we have many people saying that they would love to know that their healthcare professional has diabetes, because it would give a new level of empathy and understanding of how it is day-to-day real-life management of the disease. But also some people would feel a bit judged, saying, well, you're a healthcare professional, you have diabetes, so you must be doing everything right. So how do you feel about me not doing this? So we were discussing about what would be a good way to disclose this, since it brings so much positivity, but also without the negativity of making the person feeling judged. So if you have any thoughts on this?
yeah,
Well, sorry, Emma, that's a really interesting debate that we have in mental health and psychotherapy. And certainly in psychotherapy, we are not meant to give too much information about, in fact, no information about it, because it's not the patient in the room is the person that needs the 100% attention. And the view is, the philosophy is that it's not about us. We are meant to be a blank screen. We are meant to be objective. And as soon as we start bringing information about ourselves into the consultation, it stops being about the patient. It starts being about us and the patient. So I think that's the sort of the viewpoint from a psychotherapy perspective is to keep the amount of information we keep about ourselves to a minimum. However, I think in the diabetes setting, there's obviously different views. So maybe we can go to Debbie, and maybe Kelly and Debbie, we can have this discussion a bit later. So thank you very much, Debbie, as well, for being patient and listening to us. And I can see that you've been really nodding your head quite a few times. I've known you for many years on and off, but never really had a chance to talk to you. I've always seen you in meetings and so on. So now's my chance. So tell us a bit about yourself, like approximately how old you are, where do you live, and what do you do for a living?
Sure. I've been really enjoying the conversation so far, and thank you for inviting me on. So I was diagnosed with type 1 when I was 7. I'm 46 now. I know I don't look it. So I've had it a long time, and if I'm completely honest, I can't really remember not having it. My husband's rubbing his chin in the background about my comment. So I decided to become a psychologist. So a bit different to Kelly. I decided quite early on. So I decided to study psychology because I was just fascinated by people and what makes people tick. But also I went to a conference for young adults with type 1 diabetes, 18 to 30s weekend. It was fantastic, organised by Diabetes UK many years ago now, and not sure that they do them anymore. And at that conference, I was just fascinated by how different people respond differently to the same condition, and I was hooked really after that. I was doing my degree and then decided to do my dissertation on type 1 diabetes, partly from being lazy because I thought I already know about that, it'll be easy to write it. But also I was very, very interested. So yeah.
You did a PhD in diabetes and psychology.
I did, although I wanted to do my PhD in diabetes and psychology, but I was steered away from it by my prospective supervisor. I think he thought it was potentially a bit unhealthy to focus on, to do, a PhD is such an intensive thing. And I think he wanted me to broaden my horizons a bit. So I did actually start a PhD on inflammatory bowel disease, Khalida.
Right.
And collected an awful lot of data.
Yeah.
And then had the opportunity to switch my PhD onto this big randomized control trial looking at the efficacy of continuous glucose monitoring devices for people with type 1 and type 2 diabetes. And I jumped at the chance. My friend was looking after that trial and said, Debbie, I think I'm going to recommend that you do it. And I was like, oh my God, thank you so much. So my supervisor who'd steered me away then needed someone to work on that study. He was like, yeah, you come and work it.
So do you think that he was wrong, or she, your supervisor, with hindsight?
I do think he was wrong. And it's really interesting because he actually, I found out subsequently that he has quite severe dyslexia and had done his PhD on that topic.
Right. So he was bringing his baggage.
Yeah, maybe.
Your needs, isn't he? We were just talking with Kelly and with Emma's comments from the chat function that, do we really want to know what our supervisors, our health professionals, do we really want to know their stuff when we've got our own agendas and our own development or clinical needs and emotional needs? It's a really interesting debate, isn't it? Because of his stuff that his reservations, you couldn't fulfill your career aspirations.
Yeah. Although I did in the end.
Yeah, exactly. You were around it. You've got good self-esteem, so that's really good. So tell us what your research has been since then.
So I've worked on, I mean, it's hard in the world of research to always work exactly on what you want to work on, isn't it? But after working on that continuous glucose monitoring study, I learned so much from that. I learned a huge amount. It was brilliant for me, and it was a great study as well. I'm very proud of it. And I've done a lot of work on Daphne, which lots of people will have heard of, and some people dialing in may have been on that course. At the moment, I'm actually working on a big project with people with type 2 diabetes, and my husband has type 2 diabetes as well. Not that that's why I'm doing it, because there's a huge need out there, I think, for online self-management interventions that people can quickly and easily access. And I think that we're not very good at providing that kind of lifestyle support within the NHS. Healthcare professionals aren't really trained to provide that. So that's one of the big projects that I'm working on at the moment.
Kelly's described really quite painful experiences of stigma of being both a health professional and managing her diabetes. I mean, what's been your experience of being, you're not quite a health professional in the same way.
I don't work clinically.
But you work with a lot of other clinicians with diabetes. And what's been your experience if you've turned up to the GP or the diabetes clinic saying I'm a psychologist? Are they expecting a lot from you as well?
So, do you mean when I go to see my healthcare professional?
Yeah, and when things aren't right with your diabetes.
Yeah, sure. I think I tend to keep the I'm a psychologist out of the picture. And when I have brought that up, they're not interested. So sometimes they are. Like, there's been the odd exception where they're really interested, but generally they're like, they've got their agenda and they're sticking to that. And what I do for work isn't really of interest. So
what do you make of with your working hat?
Yeah,
being a person with diabetes in a consultation, what have you observed then? What do you think has gone well? What doesn't go well?
It's always many of my consultations, even now, it's all about blood glucose, nothing else. And it's all about not about how I wish we could talk a bit more about how those make me feel, how the high blood glucose makes me feel. And I just think I talked to a psychologist recently, this is in a work context, and he's retired now, and he'd been working with people with diabetes for years. And I said, I am just so fed up with the amount of time that I lose in my life from my diabetes. If I've got a high blood sugar and I'm not as with it. So we all have off days, don't we? But I think if you have diabetes and your blood sugar's up or it's down or whatever it's doing, it actually means I'm not as with it, and I'm not working as well, or I'm not as nice to my family, and I accept that, but I find that really, really frustrating, and I don't think there's maybe enough acknowledgement of that in clinic, and it is, and they often, the healthcare professionals that I'm talking to, they do understand that, but it's not expressed to me. I don't feel, they're not saying it to me, and they're saying, yeah, we need to get rid of these highs and we need to get rid of these lows, and so it's all about the blood glucose. So I think the focus isn't maybe about me and how I might be feeling.
So where do you get that outlet then? Where do you ventilate that? Where do you emotionally process the psychological burden of living with diabetes?
I think online, social media. So the last few years has been amazing. Twitter, the blogs that you write, Kelly, that many other people write are fantastic. And I think because type 1, there aren't as many of us as type 2, so you're not necessarily going to walk around and bump into people. And I think that community, I really feel that that's like my tribe, my online tribe, and that consists of healthcare professionals who maybe haven't got diabetes.
Actually, and what I'm interested in is when you listen, I often tell people in my clinic, patients that I'm looking after and working with, go to the online community, because and they're often sometimes quite perplexed. What do you mean? I mean, does it actually make you change your self-care behaviors? Like, will you read a blog or a tweet and say, oh, I will put that into practice and try that? Or does it help you in looking after your diabetes, or does it provide more the sense of an emotional community where?
For me, and it's going to be different for different people, isn't it? For me, I think it's knowing that there's other people out there who are like me and who are having exactly the same sort of daily issues as I am, and I can tell my husband about that, and he understands, but not in the same way, because he doesn't have type 1 diabetes, so I think for me it's that emotional,
What about in the workplace? You've described being a psychologist and then being a person with diabetes having a consultation, but what it's like actually in the workplace, in the university office, open plan officers and so on. What's it like looking at your diabetes with your work colleagues?
So it's really interesting sort of about disclosure. When I first started, so I work in a school of health sciences. So I'm one of a handful of psychologists there, and the undergraduates who we teach are all nurses, paramedics, and midwives. When I first started there, I said to the head of school, I need to tell everyone that I have diabetes in case I have a hypo. And she said, right, so if you can put an email together and then I'll just send that out to everyone. And then that kind of freaked me out a bit. and then a couple of hours later, she said, right, have you put that email together yet? And I was like agonizing over how to word it. And so I didn't sound, like I was going to be conking out every 5 minutes. But
that's what he was saying, isn't it? All of a sudden, your diabetes isn't yours anymore. It has to be shared with everybody. Everybody has to be shared, and everybody wants to comment on it. And that must have been quite an awkward. You would have been in your mid-20s, still quite a young person, having to.
Oh no, I was in my. Oh no, that wasn't that long ago. I mean, that was mid-30s.
Right. Okay.
But I think. So in the office, I think it's okay, it's fine. Like everyone knows I'm diabetic. It's interesting, in some of the research studies that I've worked on, I've not been willing to disclose, like working on the Daphne project. I mean, obviously I did disclose quite quickly to the wider team. I had a very interesting thing that happened maybe 2 years ago, where there's another woman with type 1 also working on the project. And at the beginning of this big meeting, she stood up and she said, in the interests of, or as a conflict of interest, that I have type 1. And I thought, and it made me feel so strange, because I thought, I've never done that at the beginning of a meeting. Should I be? I mean, everyone there knew that I had type 1 because I've been working with them for years. But that wasn't something that I'd ever done. I thought maybe I should be, but I'm not sure I feel comfortable doing that. It's
really interesting, isn't it? I mean, there's so many different ways in which one, what Kelly is saying, what people are saying in the chat function, and what you're saying. There's so many different ways in letting the other people know about your diabetes in the workplace, aren't there? You can go in with really ill diabetes in A&E, or you can not declare it at all, or you go to declare it as some kind of, I've not heard that phrase, as a conflict of interest, as if somehow you're competing with other people, or so it's quite interesting, isn't it, that there are a range of ways in which you can let other people, or send it around as an email. So I think that is an area of work, I think, that we need to do as a society, isn't it? That we need to have a more of a dialogue of how to have a chronic condition like diabetes in the workplace, and how you can get on with looking after your diabetes without feeling humiliated and being supported
and judged.
So thank you very much, Debbie. What we're going to do now is ask Emma to come back to our wonderful people who are listening and get some more feedback about what kind of questions are being asked or statements that are being made.
Thank you, everyone. So Debbie, I think, pretty much just answered the question that we have. So Kelly, this one is for you. do you have an experience to share where you told the patient that you have type 1 diabetes, and how did that go?
So within my role, I work within like clinic settings and facilitate some education programs as well. And I don't go out of my way to tell people that I have type 1, but obviously if I've got Dexcom or Libre on, it's been seen, and I've delivered a Libre start group. And I think at the time I was wearing a Dexcom continuous glucose monitor, so everyone could see. No one really asked, but they knew that actually that person has diabetes, and I didn't need to share it. And then there have been times where I've had someone say to me, you don't know what it's like, and I'm like, actually, I know, I understand what it may be like. I have type 1 myself, but I don't understand what it's like for you. And I always make that very clear, because whether it's shared with the patient group or the individual person, it's my experience. Yeah, we may have similar experiences, but we don't have, I don't know what it's like for them, and they don't know what it's like for me, but we know what it's like to have a hypo. We know what it's like to have the stigma or the comments, but our responses and our feelings are very different. And I always make sure that I can validate their feelings too, because, you know, it's just, that's their diabetes. But I was always really nervous as well to let people know, because I thought, I don't want people to know that I have type 1, and I don't want to take that away from them as well within a group setting. But everyone said back and said, actually, it's been really helpful. It's nice to know that you get it. You have that shared experience with us, and it's been quite helpful. But I don't necessarily go out of my way to.
Yeah. Sounds like Kelly, you found the right balance, which is that you're open and honest about wearing your Libre and Dexcom and so on, if you want to, you know, and you don't tell people immediately, but if they ask, you confirm it.
Yeah.
And I loved what you said about, you know, I thought that was such a lovely way of telling them, I've got diabetes and I acknowledge that you have, but my experience of diabetes may be very different from yours. I thought that's a really nice way of sort of saying, okay, I've got diabetes, but now let's get back to you, the patient.
Yeah, and like you're saying, Debbie, as well, the high blood sugars, I would imagine most people would say, yeah, I get quite cranky and I feel awful and I can't focus. And with some of my the young people that that come to clinic or on our group educations, I have that, you could kind of have a little bit of a joke around and be like, oh, does anyone else, me personally, I've become quite horrible, and you can kind of just share that little bit, and it brings people out of their shell a little bit. But again, it's very dependent on each person in the group that you have, whether or not you kind of get a sense of this may be useful to have that shared experience, or actually no, because this isn't appropriate right now. But you've got to be really in tune with other people's feelings. And I think when you have a long-term condition, or you have an experience that you've gone through, or say, for instance, you have a child that has an illness, and then later on you're looking after a child who has a similar illness that your child had, you're in tune with how that parent may be feeling, so you kind of have a little bit more compassion towards them, and you kind of relate to them a lot more. And I think that's what can happen, where it's very relatable and it can be helpful, but to an extent.
Yeah, I think that we should, I mean, I don't know, Debbie, if you're how much you're still involved with Diabetes UK conference, but I think that would be a great topic for the next Diabetes UK conference, wouldn't it? If you've got diabetes as a health professional, to what extent, if at all, should it be shared with a person with diabetes? It's just a really good conversation, because it's not, you've also got to some of you may want to protect your privacy. I suppose it boils down to, how do you use your own knowledge of diabetes as a person with diabetes to help the patient that's sitting there with you, isn't it? That's the sort of the noble thought of it. How can your knowledge of it help the person that you're supposed to be helping?
Absolutely. I think that clinical that empathy is hugely important and that judgment about when to disclose and how, and is that going to help in that context? And like you say, Kelly, it may not. It's not going to help necessarily in all contexts. So that's quite a sort of careful line to walk on, isn't it? But incredibly important. I mean, I remember years and years ago being with, you know, again, a conference for young adults with type 1 diabetes, and my friend had a really bad hypo, and he'd been wandering around this city that he didn't know hypo, and then he'd managed to make it back, and he was okay. And it was actually another person at the conference who a young adult with type 1 who was a nurse, and she just didn't get it, because I suppose she'd not had that experience of quite severe hypo, and so she just couldn't get it. She was like, well, how's he ended up in that state? And, you know, it was really quite not very sympathetic at all. And I was just like, oh my God, poor Jerry. You know, this is what's happened to him. So I think that ability to empathise, and what you were saying, I really loved what you were saying about yeah, being able to put yourself in other people's shoes, and that you know about your experience, I know about my experience, but I don't know what it's like for you, Kelly, to live with your type 1, and I would never pretend that I did.
Yeah,
it's so important.
Yeah, we should try to write this up on our tweet and sort of send it as a mantra. Are there any other questions, Emma, or statements that people have made?
We have a very interesting statement that is about how the healthcare professional should probably disclose their diabetes to colleagues, just in case they themselves have a severe hypo, because people have talked about their GP, for example, who for 40 years has never said anything to anyone. So they think that might be a bit safer for the healthcare professional themselves, actually. That is very kind. Also, they have been asking in the chat function about peer support. So Debbie and Kelly, do you have anything that you would like to suggest, any resources, anything that people could use?
So with my experience, I went ahead and set up a peer support service in Hampshire alongside some other people with type 1 and type 2 diabetes and some healthcare professionals. That's been going for about 6 years now, and we've been working alongside our local trust to promote it, and it's been amazing. It has been, you meet people and connect, and you can go on, we've had some charity events where we've climbed Snowdon, some people of which have never thought they'd be able to do that, but they've done it alongside others who have diabetes, and we know that people need to stop and have a break, and there's no judgment at all. It's like, what are you doing? Not what are you doing? Oh no, we need to keep going. It's like, oh goodness, you're hypo again, come on. And we all get out our supplies and make sure they're okay. And by having that peer support, people have been able to achieve and do so much more than they thought was possible of having diabetes. With meeting at coffee shops or ice cream parlors, I've had people say to me, oh, and my other friends like, oh, you're actually going to eat that. I've never had that for years because I can't manage my blood sugars. And then we share what we normally do. And then people are like, oh, well, I can do this. So signposting to peer support is a huge, huge benefit. And actually, I'm sure it helps the healthcare professionals as well, because as healthcare professionals, we can only advise on the clinical knowledge that we know. But actually, the real life experience is coming from those living with the condition. And therefore, people can ask those questions that they may not want to ask in clinic, or you may not be able to answer as well as someone else, and just say, do you know what? Yeah, it's really rubbish having a hypo, or yeah, that happened to me and it was awful, but, and then they can explain. So we've got a really good service within Hampshire and Dorset. We've spread to Dorset now, and hopefully some other areas we can help up support, because in my opinion, and I think many others, it's so important, and you don't feel alone, and your feelings are validated. You're like, actually, this does happen to other people, not just me. How about you, Debbie?
Thank you. Emma, are there any other points and comments being made?
That is it from me for now.
Great. Okay, so thank you. Thank you, Debbie and and Kelly. Rebecca, would you like to present us this week's online resources and take us through them?
Yeah, of course. I'll just share my screen with you so we can go through it. Can you see the screen okay?
Nearly.
Nearly.
Yeah, there now.
Okay, great. So on the kind of lines of peer support, a few of you know about this already, but it's always good to look at the Diabetes UK support groups because you can find one in your local area and you can search for that. Also, I know at the moment a few are doing sort of online support, which they wouldn't normally do because of the COVID circumstances. So it might be worth them checking it out if you haven't done so previously, because they offer kind of different support to usual. And then Kelly was describing Sugar Buddies, which he co-founded. So they have their website here, which I'll share on the chat in a bit. And also they have a great Twitter account with lots of useful things that they share, which is @sugarbuddies1. I don't know if you wanted to add anything, Kelly.
Yeah, we have a closed Facebook group, which is to be fair, our website needs a little bit of updating, but yeah, we have a closed Facebook group for people who live within Hampshire and Dorset, and that's open for all types of diabetes and also parents and carers of people with diabetes as well. And that's at Sugar Buddies Hampshire and Dorset.
Thank you. We'll make sure we'll share that one as well. And then our third resource, if I can click on it, is a new website, Diabetes Psychology Matters, and they have a lot of resources on there about COVID-19 at the moment. So different things, relaxation, deep breathing, and something about anxiety and worry, and self-isolating when you have diabetes. So there are 3 resources this week, which I'll share on the chat and we'll put on social media as well.
Great. So I think that we would like to start drawing it to a close. And Debbie and Kelly, and maybe Debbie first, have you got any additional points that you would like to make based on the discussions that we've had?
No, nothing additional other than to say, let's think about Diabetes UK.
Yeah.
Great idea.
Yeah, great question. And Kelly?
Yeah.
How have you found this meeting? What have you sort of got from talking about yourself in this way at this meeting?
It's really useful to obviously share our experiences, just so others are aware that actually as healthcare professionals, we're not can't think of the word I'm looking for, but we have these comments made to us too, and we're not alone. Like,
yeah.
We share these experiences with other people. Yeah.
So thank you. Pardon?
We're not robots. We are people as well, and we still have our ups and downs with our diabetes.
Absolutely.
So thank you very much to Debbie and Kelly for joining us. It's been a really, really interesting discussion and debate, and I don't know if you've arrived at any answer, like one-stop statement, but I think what it has done is open up to a very interesting question, which I think could actually lead to better patient care if we had a better way of understanding or thinking what would be a good consensus on how we talk about our own diabetes. And I'm not just thinking about type 1, but increasingly more and more health professionals have type 2 diabetes. So I think, how can we use that in a constructive way for the people that we look after? And I want to thank Rebecca and Emma for facilitating the aspects of the webinar, and we look forward to meeting you all next Thursday. Thanks very much. Bye. Bye.
Bye.
Bye.